Uh, Thank you, Vanderson. I first off want to just echo what you just heard in terms of support from NIH. What I'm going to talk about, both the science and the clinical implication of our findings, would not have been possible without support from NIH. Quite frankly, almost all of it was supported by NIH. So with that, so graft versus host disease, it's a major complication of allogeneic bone marrow transplantation or hematopoietic stem cell transplantation, which the transplantation modality itself is actually curative for potentially several malignancies. The problem has always been that it comes with a huge complication called graft versus host disease, which occurs in over a third to half of the patients, depending on the type of transplant. Histone deacetylase inhibitors, these are anti-cancer drugs that have been around for a while, and not too long ago, FDA approved for one particular type of lymphoma. We have spent the past nearly decade studying this particular medication and its implications. And what we found over the years is that this particular drug can actually, in addition to killing cancer cells at much lower doses, it can reduce inflammation and increase a subset of T cells called the regulatory T cells, and in animal models, it reduced graft versus host disease. And some of those references from our lab and others are shown below. So given those, we were excited, and we wanted to see if this really translated into humans. So these studies were done in mice, and we understood some of the biology behind it. And given the drugs available, we wanted to see in a proof of concept clinical trial if this panned out in humans. We started with a hypothesis, just as you do any scientific endeavor, that HDAC inhibition or histone deacetylases, that's what HDAC stands for, inhibition will be safe and reduce graft versus host disease in patients who are undergoing matched related donor, or it's one of the types of transplant, following reduced intensity conditioning. And as controls to see if our intervention was effective, we used historical controls who received the standard prophylaxis for prevention of graft versus host disease, or GVHD. And the idea is that the primary endpoint to look for, what we decided to look for scientifically, was to see a reduction in the rates of graft versus host disease from 48 to 25% by day 100. That's a typical cutoff for when most of us use as predicting for calling it graft versus host disease. So with that, this is the study design. We had the IRB approval, and we, as I said, we had funding support from NIH, as well as from Leukemia and Lymphoma Society, and the drug was provided through Merck. And along with Washington University, we at University of Michigan launched this trial in 2009. It was open to all adult patients who were receiving reduced intensity transplants, and some of the details of the type of transplant are listed up there, and the diseases for which patients were getting transplanted were mostly acute myelogenous leukemia and a few non-Hodgkin's lymphomas and myelofibrosis. 47 subjects are currently valuable. The goal of the study was to get to a total of 50, but the data have been promising that at 47 we've decided to show this. We had two components to the trial, a phase 1, which really included was primarily for toxicity purposes, and then the phase 2, which is for efficacy purposes. So this is the scheme of the study. It was based on the standard reduced intensity regimens that is used in treating these patients at many places, fludarabine and busulfan for 2 days, again, over a standard backbone of graft versus host disease prophylaxis at our institution and many other places, which is tacrolimus and mycophenolate mofetil, or MMF, and the study drug based on our experiments. It's called vorinostat, that's a trade name, which is a histone deacetylase inhibitor. And we gave it at the dose shown there, as we studied 2 different doses. And the endpoint, as I indicated, was graft versus host disease, which is measured in terms of severity from grades 2 to 4. Grade 1, usually nobody treats it systemically. We just use topical or actually just watched. Grade 2 to 4 are the ones that are treated, and it's the grade 3 and 4 is really the worst, where the mortality rate, especially for grade 4, is as high as 90%. So these are the patient characteristics with the between the study control and the study patients. As you'll notice that the age was higher in our study group, and usually older patients tend to do poorly with allogeneic bone marrow transplant. Again, the study patient was slightly higher age. There were no differences in what we call engraftment, where the donor cells have taken home and have started to make new cells, and we measure it clinically by looking at 2 types of cells called neutrophils and platelets, and there's really no difference in the rate and the time to engraftment. There were complications noted, thrombocytopenia, which is not uncommon post-allo transplant. Nonetheless, it was higher at the higher dose, which is in the phase 1 component when we studied, and we backed down to the lower dose of 100 milligrams twice a day. And there were issues with nausea, again, primarily at the higher dose. So the exciting thing for us, as I indicated, was that we tried to translate some of our biological observations from experimental models, in which we showed that acetylation of a particular protein called proteins called histones, H3 and H4, they're the subsets of those proteins. And what we found is that in those patients who were getting the study drug at higher levels of histone acetylation, suggesting 2 things. First, that the dose we were using was sufficient to hit the target, and secondly, it dovetailed nicely with our experimental studies. And here's the primary endpoint, the thing that really matters, the clinical outcome. Shown in the blue curve is the study outcome, and the red curve are the historical controls. As I said, historical controls were 48%, and as you can... And the study patients were in the 22% range. So it's a significant reduction in the rates of grade 2 to 4 graft versus host disease. And as I had started telling you earlier, that it's grade 3s and 4s are the ones that where the mortality, especially for grade 4, goes up to 90% of these patients die within 6 months of the diagnosis. And if you look at it, in the control patients, it was in the order of high 20%, whereas in the study patients, it was actually 4%. It was just 1 patient who had grade 3-4 graft versus host disease, suggesting we not only reduced the overall rates, but we likely impacted on the more severe form of graft versus host disease. And in terms of safety and toxicity, just for completion's sake, again, the details are available. Dr. Choi, my colleague, will present it tomorrow. There were really no big differences in infectious complications. Actually, off note, we had no fungal infections in our sample. We had no other standard known side effects from allogeneic transplant were not increased, and the causes of death were really not any different from those that had received without the drug, the standard transplant. So in conclusion, what we found is that administration of this anti-cancer histone deacetylase inhibitor called vorinostat can be administered safely, and we gave it from day -10 through day 100 in patients who were undergoing reduced intensity transplant from match-related donors. And what we found is that it also reduced the cumulative incidence of grade 2 to 4, the bad graft versus host disease, substantially. From a biological standpoint, we found that using this drug, just as it did in our experimental mouse models, we were able to reduce inflammation through measurement of different cytokines, as well as increase acetylation of certain proteins, suggesting we were hitting the target as we were predicting based on our experimental studies. We also increased these cells called the regulatory cells, which really have salutary effect on graft versus host disease outcomes. patients. And our data actually demonstrates translation of our experimental studies into a proof of concept human trial. Obviously, this would need to be studied further in much more randomized controlled trials, which is really the gold standard for measuring efficacy. But we're very pleased with our results so far. Thank you.